So case control studies are very different from the two that I've mentioned there, because the starting point for these is a group of people with a disease. And especially if we're looking at a disease which is fairly rare, if we're looking at severe trauma, if we're looking at other rare mental health conditions, maybe psychosis, then we might only see a few people. And if we want to study the prevalence of disease, we'd have to have a very large sample size in order to get just a few cases of this particular mental health condition. So what we might do here with a case control study is start by identifying the cases that come into a hospital, or if we did some community testing, we might identify cases that we have in our community. And we might recruit then as many as we can into our study, so that we can say we have a number of cases there. However, we're not going to then look at the whole of the rest of the population, because there'll be a lot of people there, a lot of information that we would collect, which we don't actually need. But we then identify a suitable number of controls who don't have that condition and who are similar to the ones that we have recruited as cases, and we can recruit them from the population. But it would only be a small fraction of that population that would be recruited into our study, those without the condition, and we would say that the sampling frequency for that, so the controls, would differ from the sampling frequency for the cases. And that's the key thing about case control study, is that the sampling frequency of the case be quite high. We might be getting everybody who is a case into our study, but the sampling frequency for the controls might be quite small. We're only 1 in 100 of our controls into our study from the population. But the important thing is that from both the cases and the controls, we will get a complete history of the exposures, whether they had suffered childhood abuse, whether they had suffered stress, whether they had attended particular courses or universities, or worked in a particular conditions. And of course, those are all might be risk factors for becoming a case later in life. However, the issue here is that with case control studies, there may be biases, recall biases, as cases may have a better recall of some of the key events because they've then experienced a particular mental health condition later in life. The other thing about case control studies is that we can't measure the prevalence of disease or the disease in a case control study, because we're not selecting cases and our controls with the same sampling frequency. We the odds and the odds ratios of the condition or the outcome in our, and this is very important because that enables us to do some very good analytic studies using case control studies, where we're looking at odds ratios for risk factors, and that's some of the early work with smoking and lung cancer using case control studies where they identified smoking as a risk factor for lung cancer using those methods. And so I think also with mental health conditions, we might have some very rare mental health conditions that we're going to be looking at, and we could do cases and controls taken from the population or taken from secondary data in order to be able to analyze those data. Okay, the final one